Hey everyone, I'm Patrick. I'm an infectious disease specialist from Washington University, as was just mentioned. Sorry for those of you who have to, listen to me chat again. I've done a number of these, but this is actually the first time that I've been invited back, so much appreciated for that. I sort of split my time seeing patients in the hospital, so the sickest of the sick, people don't know what's going on. If they think there's an infection, I get called to sort of help figure out what's going on and how best to treat folks. So I usually start with a couple things like the elephant in the room, and these are like the biggest sort of concerns about the vaccines. And so I start off with what they are. So I think probably by and large, the biggest sort of misconception about vaccines is that vaccines prevent you from getting an infection. That's not true, okay? We would like to think that that's the case, but truth be told, if you are exposed to the flu virus, right? You're gonna have someone accidentally sneeze or cough in your face during flu season. That virus is going to be able to sort of get into your mouth, your nose, and sort of start replicating there within those tissues. But what the flu vaccine tries to do is it tries to teach your immune system that when it recognizes that virus, that it is going to mount its response faster. And then really its ultimate goal is to prevent you from getting real sick, okay? So you can still get an infection, and I'm sure that people have heard in the news about breakthrough infections and the number of people who are fully vaccinated getting infections. People will still get infected. What we're trying to do, again, train the immune system to respond faster, stronger, to keep you from getting to be the person that's intubated on the ventilator machine in the ICU. If you come down with the sniffles, I'm sorry that that happened to you. But again, if that's all that it is, that's much better, than potentially being really sick, being hospitalized, being in the ICU. So that's really sort of the goal of the vaccine. So again, we will see numbers. People will have breakthrough infections. That's sort of the name of the game. And so whether that's the COVID vaccine, the flu vaccine, measles, mumps, rubella, we've been working on this whole vaccine thing for over a century. Sort of the next thing is, did we rush these vaccines? So as I said, we've been working on vaccines and vaccine technology for over a century, and so this isn't really anything new for us. What tends to be a little bit new with the COVID sort of vaccine specifically is some of the technology that we're using to produce the vaccines. And so the big one is the Pfizer and the Moderna vaccines, which were made of mRNA. So yes, we first learned about COVID late December, and within about a few months even, we started thinking about vaccine trials. So that mRNA technology, we didn't develop it once we found out about the COVID virus. That's been going on since the 1980s, sort of the technology with mRNA. And then for the last 2 decades really, large pharmaceutical companies have sort of been putting this in the wings, doing some work on this every year, just in case we were faced with a situation like the COVID-19 pandemic. So this isn't something that took 6 months and we got it from, start to in the first person's arm. That's not how it happened. But it was new for the first time for use in COVID. And so the next thing is, did we rush it to market? Did we test it enough? And so the thing about that is no steps were skipped. And sort of the way that I like to explain this is that we didn't rush it. What we did is we paid for expedited shipping. So we paid for expedited shipping in a couple ways. The first way is that we sort of overlapped a lot of the clinical trials. Normally, it is not a good money investment to run phase 1, 2, and 3 clinical trials all at the same time. The reason that's not a very good money decision is because if phase 1 fails, you should stop because you shouldn't go any further with that technology, that medicine, that chemotherapy. It's just not worth it. However, because of how many people this was affecting across the globe, people thought this is a huge problem, and governments, nonprofit organizations, research institutions, they all said, you know, to heck with the money issues, we're going to do phase 1, and then we're sort of going to overlap some of these subsequent trials, and so that way we can do them simultaneously. And if it doesn't work, it would have been wasted money. But we got pretty lucky with a couple of the vaccine manufacturers and got some pretty amazing vaccines. So that's one way we paid for expedited shipping. Now, the way that a clinical trial runs, particularly for these vaccines, is we recruit a whole bunch of people. So it was between 30 and 40,000 individuals for the phase 3 trials, depending on whether it was J&J or Pfizer or Moderna. And what we do is we just split people up. The patients don't know, the researchers don't know, the company doesn't know, nobody knows how you get allocated. Some people get a placebo, some people get the vaccine, and then we wait. And the thing that we're waiting on is for people to get sick. And so the bad part about this is that so many of our community members, our countrymen, and world citizens, because the COVID virus was spreading uncontrolled, we didn't have to wait very long for people to get sick. So before we start the study, we say we need to wait until we get X number of events. And so it's a little bit different for each study. So I will make up a number, say we need 200 infections to happen. Once you reach that predetermined number, everyone gets unblinded. We say, person A got placebo, person B got the vaccine, and then we, split everyone up who had the infections. And then what we want to see is that 198 of the people who had infections had placebo. Only 2 of them had the vaccine. And then we say, great, that works really well. And so because of how widespread and how much community spread there was early on in the pandemic, particularly here in the US where a lot of the trials were being done, we reached that predetermined number really fast. If these trials would have been done, say, in New Zealand, when they got control of the virus really, really fast, the trials would still be going. So we didn't speed anything up. It was an unfortunate sort of effect of the pandemic that we had people sort of paying for the expedited shipping with illness and loss of life. So we paid for expedited shipping that way as well. The last thing, and again, this sort of goes back to money making and, big pharma and that sort of thing, is nobody wants to produce something ahead of time if they don't know that it works for sure. However, this goes back to governments and nonprofits and all of that sort of thing. They dumped a bunch of money in these companies to say, hey, we know that we don't know that it works yet, but what we want you to do is to start making these vaccines, and we want a big stockpile. So that way, the second that we know that they're good, they're safe, they're effective, we can start rolling it out. And so, in my opinion, this was a marvel of modern medicine that we got these out so fast. And I think it's truly, truly a marvel. But none of it was actually rushed. It happened quickly, which was a good thing, but all of the steps happened sequentially as they're supposed to. We just paid for expedited shipping. Pfizer and Moderna, those are the mRNA vaccines. I use different metaphors for different groups of people, so I will try to use one for maybe applicable to you guys. mRNA is essentially a blueprint, and it is a blueprint for your body to make a protein called the spike protein from the SARS-CoV-2 virus. And so mRNA, much like blueprints, I'm only going to take one page out of the book of blueprints. And so that is the one page that says, this is how you make this protein. We give it to your body says, okay, I understand this one page of the blueprint. It makes that spike protein, your immune system recognizes it, and then trains. And it trains that if you ever find this in your body, attack it, destroy it, and you'll be good to go. Now, if I asked you to produce an entire building based off that one page of a blueprint, I don't think that there's anybody that can get that done. And so much like the mRNA, or much like the blueprints, the mRNA vaccines, you can't make the whole virus. It doesn't contain the information to make the whole virus. It is not the whole virus itself. It's just one page of a blueprint to make one specific aspect. And again, you know, if you're walking around a job site and you have that just one piece of paper, and you fold it up, put it in your pocket, pull it back out, lay it down, you know, put the edges down with rocks, it's not going to last very long. It's going to get ripped, it's going to get muddy, and it's going to get destroyed. And so you roll it up, you keep it in a tube, keep it safe. So the mRNA vaccine, that piece of mRNA is just still like that page of blueprints. It doesn't last very long. Your body does it a couple times, it makes some protein, and then that mRNA is destroyed. It doesn't go into your DNA, it doesn't go into the nucleus of your cells, it doesn't reproduce. You use it a couple times, and then it degrades. So that's pretty cool. So you get the training. There really isn't much sort of leftover material of any kind. And so that's more or less how it works. So you get the blueprint. It creates the protein. That protein sort of acts like a wanted poster and says, wanted SARS-CoV-2 virus, immune system, you see it, you destroy it. There's a couple other types of vaccines. So Johnson & Johnson, that uses a shell of another virus called an adenovirus. It's a different family of viruses, but think of it sort of like the plastic Easter eggs that has the candy in it. The adenovirus is that plastic Easter egg. Doesn't have anything in it. It's just sort of a container to keep other things in it, okay? And so we put the little piece of the spike protein, you know, in that sort of candy Easter egg shell. And so it doesn't reproduce, it doesn't have any genetic material to sort of spread or to be contagious or anything like that. It just provides that one little piece. And so again, this is technology that's not new. We've sort of adapted it specifically for COVID, but this is something that we've been working on for decades. This is the same sort of type of vaccine that we used when we created the Ebola virus back in the early 2000s. The original sort of SARS virus that we heard about, again, sort of early 2000s. It was mainly in the East, and there were some cases in Canada. But that technology is not new either. We've been using it, again, for decades and decades.
For all three vaccines?
Great question. So religious exemption and sort of the medical testing on embryonic stem cells. So without like revealing how super nerdy I am, I'm going to not like super dive into the science. Some of the adenovector viruses platforms, so like J&J, the technology in and of itself was developed using really old historical cell lines that were developed from embryonic stem cells. And so embryonic stem cells are cells that essentially are immortal and can sort of divide again and again and again and again. And so they're really good to test like lots of medical and sort of scientific applications for, because you have essentially like a never-ending supply. So that's why some people do that, and so that technology was used in sort of some of those vaccines. There is no fetal tissue, no fetal testing, any of that sort of stuff on the mRNA ones. So if that's an issue for you, you have an option. And then as far as I know, I'm in agreement with you. Every sort of major religious leader, has come out that says, we value the sanctity of life, and if we can prevent death, we should do so. So even the Pope, and so I think the Catholic Church has a very, very strong stance about, abortion and embryonic stem cells and that sort of thing. Even the Pope said, yes, get vaccines into arms no matter which type. So, you have alternatives if that's a strong personal belief of yours, or, if you follow some of the, larger congregations, I think most of those have come out in favor of preventing death. The question was, how much of the vaccine did we have ready to go like prior to the start of COVID? So how much of it was like a continuation on of the 100 plus years that we've been vaccinating people? It's a great question. So we've been using a lot of the various vaccine technologies and other sort of types of vaccines already. So like the Johnson & Johnson and then like the Oxford vaccine also uses that adenovirus that we talked about. So the component parts for that virus have been used in Ebola and SARS and other sort of things for decades. There's some other types that we don't have available in the US. Novavax is sort of getting towards the end of their trial. They use a protein subunit vaccine, which essentially, don't worry about exactly what it is, but that's sort of what we use for tetanus and that sort of thing. So that sort of modular technology has also already existed. And then so the mRNA part of this is beautifully set up to be modular. And so you have the technology. We've been working on the technology, not me, but like we as the medical community have been working on that technology for the late 80s, early 90s. And we just needed an opportunity to say, we need something fast and we need to be able to sort of plug it in. So the platform has been ready to go, which is why sort of Moderna, the outbreak happened in China in December. The Chinese actually published the entire genome for researchers all over the world to start, rapidly working on it. So the question is about the booster and sort of, what we're thinking about the booster. So let's talk about sort of timeline. Whether you get sick with COVID or whether you get a COVID vaccine, the first thing that happens is sort of the early immune systems take a little bit of time to recognize that this is not me, this is something else from outside that I need to take care of. And so what it does is after a number of days, you start producing antibodies. Antibodies are very specific for very specific types of bacteria, viruses, fungi. And what they do is they sort of attach to the outside of whatever the pathogen is. And what it does is it signals to the rest of the immune system to seek and destroy that particular virus, bacteria, whatever it is. Now, when you have an acute infection or a new vaccine, you get tons of antibodies early, and then that sort of wanes over time. You still have the ability to make these antibodies. There are cells in your body that are part of your immune system called B cells, and they're memory B cells. And so you've trained those memory B cells to say, hey, if I ever see this again, I'm going to reactivate these cells to start churning out antibodies again. Okay? However, that takes some time. And so your antibodies over time after getting your vaccine or being infected, for the first or second time, the antibodies wane, and so it takes time to turn those B cells back on. And so what the booster does is it sort of does that for you. So rather than waiting until you get infected and sort of delaying having lots of antibodies to help fight the virus, you get a booster, and that sort of reminds those B cells to say, hey, B cells, wake up, let's make some more antibodies. We have a pandemic going on. We want those antibodies at the ready now. We don't want to have to wait until you get infected. And so what it does is essentially it's just going to speed up by a couple days your immune system's ability to respond to the infection. And hopefully that couple days, that's the time period where if you waited, your likelihood of being really sick goes up a little bit. Whereas if your immune system recognizes it early, can get on top of it, this is either you being asymptomatic, maybe having a small fever, some cough, and then that being it. And so really, we're just trying to cut down on the window between being infected and mounting a response. And so that's what those boosters are doing for you. So mixing, matching vaccines, which booster, which one to start off with, that sort of thing. So sort of May, June of this year, a number of papers came out that were actually looking at that specific thing. And so they sort of looked at, both symptoms. And so if you get J&J and then get Pfizer, or you get Pfizer then Moderna, or any of the other sort of combinations, did people respond worse or have worse side effects of the vaccine if we did a certain pattern. Okay, so that was the first one that came out. The second one was then how robust was the immune response? How high were the antibody levels in your body based on which one came first or second? The current sort of company line with all of the data that we have currently would suggest that it probably doesn't matter a ton. There is some variation, sort of what comes first, what comes second as far as how high the antibody levels get. But overall, as of right now, it's sort of the recommendations are if you got Pfizer, get Pfizer. The Moderna, get Moderna. Johnson & Johnson's not quite out with sort of the approval for the booster, but that's sort of it. Does it hurt anything? Not that we've found so far. So if you get one and then get something else, we haven't found that it's harmful for folks. We just don't really have enough data to provide strong recommendations. This is actually a little bit near and dear to my heart. So infectious disease doctors, whether you have COVID or a staph infection or HIV, we treat everyone. And so I have, expertise in a lot of, these areas. But what my research is on fungus. And so Missouri is a great place for fungal growth, where we have the Mississippi River, the Missouri River, the Ohio River. They all kind of come together. It's warm, it's humid. And so there's a type of a fungal infection where in my patients that I treat in clinic, I see a similar sort of, they get infected, I treat it, I know the infection's clear, but they remain tired and they have headaches and confusion. And so one of the things that the pandemic has brought into focus is that there's probably lots of conditions, post-infectious syndromes, whether it's, a bacteria, a virus, fungus in my case, that people have this and we need to figure out why. And the pandemic sort of brought this to light because fungal infections aren't very common, especially sort of the systemic ones that make you really sick. And so it's kind of been ignored and kind of pushed to the side. One report kind of put the number of people that had long-term effects from COVID, like over 50%, which if you think about the millions and millions of people who have been infected, that's millions and millions of people who have long-term effects. And luckily, because of lots of sort of advocacy by, folks like yourself, we've heard, the NIH has heard, they've actually now put tons of money, sort of taking it from Peter to pay Paul, which is we need to figure out what's going on. And so that's actually one of the things that I personally am researching to try to figure out the answer to that. I'm not doing it directly in COVID because I feel like we need to have a comparison. So that way we can say the immune system reacts in this way for histoplasmosis, this way for COVID. Is that a shared pathway? Is that a different pathway? So we're going at it from a bunch of different ways to try to get that done for you. So the immune system is beautifully complex, and I would venture a guess that if anyone ever tells you, I fully understand the immune system, they are either being ignorant, arrogant, or they're lying to you. It's so complex. It's wonderful, it's beautiful, it keeps us safe, but it is super complex. Sort of what I like to think that how we understand the immune system. Think about like a symphony, like with the clarinets and the violins and the drums and the trumpets, and then there's the conductor, right? We know a lot about the immune system. I know the sheet music for the trumpet player. I know where everyone sits. But if you ask me to sort of conduct the symphony perfectly, knowing where everyone sits, the trumpet player's music and the clarinet player's music, I'm not going to do a very good job. So we do know a lot, but there's still a lot we don't know. And so some of these sort of side effects we think are due to sort of the immune system attacking something that's not supposed to. So there has been some signal that in some folks that getting the vaccine also will sort of cause what we call pericarditis, or just inflammation of the heart muscle. It is my opinion that, again, going back to sort of the number of vaccines given to the number of cases that we've had, that your risk of having that complication from COVID is actually much higher. And so I'm not saying that there aren't reports of it or that it doesn't exist, but there are more sort of cases that people get COVID and then sort of have those cardiac complications. And so that part concerns me more, because not only could you have the cardiac complications, you could have the breathing problems, you could have the thing that no one really talks about a lot. We talk a lot about how many people die and that sort of thing, but we don't talk about the long-term complications, the people that can't taste anymore, the people who have like these chronic fatigue syndromes that can't get out of bed, like that sort of thing. There's no way to track those numbers, and so we're missing tons of people who are having terrible complications, life-altering complications, that we're not really including in the numbers as well as I would like. It's hard because it's really energy intensive and expensive, and we have limited research funds to get those stuff done. So again, I'm not saying that it doesn't exist, but my opinion is I'm much more scared of the virus because that's also a known side effect of that, and your risk of that is higher, in my opinion. What happens over time? What is this vaccine going to do to me 20 years down the road? Full disclosure, full honesty, I don't know. They haven't been around long enough for me to be able to tell you 100% certainty, Dr. Mazi said this or this or this was a possibility. I don't know. What I can tell you is that, again, we've been working on vaccines for over a century. And what we typically see is we don't see effects of vaccines 20 years down the road. We are training your immune system, and your immune system tends not to just hang out. It's dynamic, it's active, it does things. And so that's why you get the flu vaccine, or those of you who've had the COVID vaccine. If you develop a little fever, you feel a little bad for 24 hours. That's your immune system training. That stuff happens immediately after the vaccine, and we don't typically see, for the 100 years of data that we have on other types of vaccines, we don't see really long-term effects. So I can't 100% guarantee that nothing would happen, but again, I have over 100 years of data to suggest that the possibility of that is extraordinarily low. Let's start off with talking a little bit about side effects. So those of you who, hard day's work, or you go to the gym, or you go for that long run, anything like that, after you do that training, your muscles are a little sore. You wake up the next day, but it's sort of that good sore, like I did something yesterday, okay? That's your body training. That's not particularly comfortable, and so, but that's how you know that you did something. So the most common side effects of our vaccines are the effects of your immune system training. So a lot of times, viruses, bacteria, fungi, the things that infect you, a lot of the times the symptoms from those infections, that's the result of your immune system. The immune system raises your body temperature, and so then you have a fever. It can, create some muscle soreness. So giving your immune system a practice run at those things, those are going to be common after the vaccine. Now, tons of people only have the sore arm, just where the injection happened. But if you have a fever for 24, 36 hours, if you have some aches and pains, me personally, so I actually just got my booster because I'm frequently taking care of patients in the COVID ward, so I had my booster last week. I'm in my 30s. I don't have any arthritis that I know of. After my third dose, my shoulders hurt, my hips hurt, my knees hurt. I laid on the couch for a day, watched Netflix, and then Sunday morning woke up and everything was good again. So there are effects of your immune system training that are common. Those are transient, they last a day or two, then they go away. And sort of, if you get the vaccine, you have it, just sort of chalk it up, be like, wow, this is a medical marvel. This is the same as me going to the weight room, maxing out on bench press, and feeling a little sore the next day. Sort of the more serious side effects. So we talked about 1 in 500 Americans dying of COVID. I think probably the most famous one was Johnson & Johnson early on in its, after its release, went on a pause. And this pause was due because some folks were having some blood clots, and they wanted to make sure that it wasn't necessarily associated with the vaccine. At the time that they did that, there were 6 cases out of 7.2 million doses given. So more than 1 of a million chance of having sort of a severe side effect. And so 1 in 500, 1 in a million. Any time that we do anything at scale, so if getting struck by lightning is a 1 in a million chance, if you have 7 billion people on the earth, people are going to get struck by lightning every day. If you give 7 billion doses of vaccines, some people will go out the next day and have a heart attack. Some people will get hit by a car. Some people will have a tree branch fall on them. Anytime that the numbers get that big, we will find little ditzels of concerning data that we do need to track down and make sure it's not a bigger problem. It does not appear to be. The chances still appear to be in that 1 in a million range for a lot of the more severe side effects. And so it's balancing those versus that 1 in 500. Okay, so because we have studied extensively, we're closing in on 7 billion doses of vaccines given, and we have people all over the world that are studying how much antibodies do you make, how long do those antibodies last. We have people at our institution working in our infectious disease clinical trials unit that we're taking lymph node biopsies and bone marrow biopsies. Those are the places that your immune cells are made and stored. And so we're actually taking those from volunteers so that way we can say, how long do they last in our body? How long will they continue to protect us? And so we are answering those questions for the vaccines. So if you get a vaccine, I can pretty accurately predict sort of how you will respond. There are some populations of people that we're still working on, so people who are immunocompromised, so folks who have transplanted kidneys or livers, people who are on chemotherapy, who have had bone marrow transplants, that sort of thing. We're still working on those folks. We have learned that if we give them sort of repeated vaccines, that they sort of mount a stepwise, their immune response gets better and better and better. But the long story short, for the vaccines, it's very predictable. You get the vaccine, I'm going to be able to say within plus minus this is going to be your immune response. Natural immunity for some people may be okay. The problem with that is it is a gamble. I have no way of knowing for you after your infection what your response will be. You could be someone who has a very sort of mild illness, mounts a very robust immune response, and you may have really good long-lasting immunity. I don't know. There's a couple reasons that's really hard for me to study. One, lots of people got infections that we never sort of knew about. They were asymptomatic, they attributed it to a cold or a flu, something like that. So there's a whole portion of that population that I have no data for. There's a couple other things that we found is folks who had relatively minor, mild symptoms or no symptoms that we did catch, say they were going in for a surgery and we happened to test them just so that way we could protect the OR staff. They're completely asymptomatic, that sort of thing. Some of those people will sort of develop a proportional immune response, meaning mild symptoms, mild response. And so their immunity may not be very long lasting, okay? On the other end of the spectrum, the people who get super, super sick, the folks that are on the ventilators, they're in the ICU, but against all odds, we were able to get them off the ventilator. Their immune system was so robust, so strong, that it essentially was just going haywire. It was fighting anything and everything that it could get its hands on in its attempt to sort of preserve your life. And so some of those folks had a non-specific immune response. So they fought everything, but they didn't do a good job of sort of teaching the body how to fight COVID itself. So those folks on either end may not have very good sort of long-lasting immunity. There probably is a sweet spot in the center of you got infected, you had a really good immune response, and you may have some long-lasting immunity. That's a gamble, okay? I can't predict it for a specific individual. If you come into my office and say, hey, Patrick, I had a fever for 2 days, had symptoms for 8 days, how good's my immunity? Honestly, I have no idea. So it's a gamble. So essentially what you're weighing is a very good prediction of how much immunity you have and how long it's going to last versus sort of the unknown. And so that's sort of the comparison between natural immunity and the vaccines. The amount of virus that's able to spread in someone who has the infection, who had the vaccine and doesn't have the vaccine. I talked a lot about the mutations, and so the more times the virus has a chance to mutate, or the more times it replicates, the higher the amount of community spread that there is, the higher risk we are to develop a new mutant. So it's really important to protect our communities by sort of tamping down the amount of virus that's in the community and the amount of virus that's spreading within our community. And so this is directly applicable to your question, is how do we do that? Sort of full circle back to the beginning of my talk. In and of itself, the vaccine does not prevent the virus from you being exposed to it, from it sort of replicating in your nose, your mouth, your throat, that sort of thing. So even if you're vaccinated, that can still happen. What we have found is there have been a couple studies that show you still have a fair amount of virus that we can measure sort of the amount. But what we find is that people that are vaccinated, that you kind of get that original exposure, you sort of get inoculated with the virus, it starts to replicate, and then it, boom, shuts off really quickly. Your immune system takes over, it recognized it, it sort of shut that down. Folks who aren't vaccinated, even if it's asymptomatic, you're going to get that sort of peak early after your initial exposure, and then sort of it just takes a little bit of time, 7 to 10 days, that's kind of where we got those numbers for quarantining. It takes about that long. And so how that affects us, our families, our communities, our churches, our places where we work, is we want the amount of time, the probability that you can spread it to others to be minimal. And so again, you're vaccinated, you can still be exposed, you can still have some bioreplication, but it gets shut down real quick. So it's possible, but again, a lot of the stuff we're talking about is how do you want to play the odds, right? Do you want to play the odds that you're going to expose your family, your community for days and days and days? Or, if you happen to be exposed that it's, a day or maybe 2 days. So yeah, it's a lot less. So you get vaccinated, you get exposed, the amount of virus that you would possibly spread to your friends, your families, your community is a lot less. Great question. Does this actually cause effects to pregnant women? Does it cause miscarriages? Does it have any effect on fertility? Let's start there. The fertility issue, a lot of that comes from, do these vaccines change my DNA? I sort of addressed this earlier. Those mRNA vaccines, single page of the blueprint, okay? I can't create the whole virus from this, just that one page. That one page gets rapidly destroyed. It does not go into your DNA. It will not change your genomic sort of profile that you would pass on to a child. It does not affect the fertility. In the Pfizer trial, again, I think there was 40,000 some odd people. 23 women got pregnant during the trial. They were not supposed to, but things happen, it's life. One person had a miscarriage, and that person was in the placebo arm. So all the available data would suggest that it doesn't affect anything. As I said, we're closing in on 7 billion doses. And again, anytime you do that sort of thing at scale, we would be seeing safety signals. Our OB-GYN colleagues, they would say, hey, Patrick, go kick rocks. We are not gonna put these pregnant women at risk. They have not done so. They said, we absolutely want these vaccines in all of our patients. The American College of Gynecology, ACOG, it's in their recommendations. They look after their patients so very well. They really would. If they thought that it was gonna harm mom or baby, they'd tell me, be like, Patrick, you gotta wait. So antibodies are passed from mom to child, but not the vaccine. the protection. And so it's actually pretty important because the baby doesn't actually start making its own sort of immune responses for several weeks to months after birth. And so what it does is it actually relies on mom's antibodies to help protect it during that sort of early period of life. So that's actually a really important aspect. Good question. Can you shed virus after the vaccine? So it takes a while, so I'm going to answer this in two parts. One is sort of, you can still get infected. It takes a while for you to mount the immune response, and so your level of protection gets up the further sort of removed you are from the vaccine to a certain point till it sort of starts dipping off and you need a booster. You can still get infected, and then you will shed virus, okay? I suspect that's not what you're asking. None of the vaccines have the component parts to create the whole virus. So I could give you 8 vaccines and give you Moderna and Pfizer and J&J, and all of them, even all of them put together, they don't have the machinery, they don't have the full book of blueprints to make the whole building, okay? So you can get it, go back immediately, go hold a newborn baby. You are not going to be shedding COVID virus after the vaccine. That's a great question. Over the course of the virus, or over the course of the pandemic, the virus has gone through several mutations, and so we've had several what we call variants of interest. And they all sort of come with different sort of, for lack of a better term, personalities for the virus. And Delta really caught the world by surprise. And so sort of what I'm going to speak to is my personal experience taking care of these patients. So sort of the original SARS-CoV-2 no variant, so the OG virus, if you will, people would get sick, and those who got really sick and had to go on the ventilator, I felt like we had some success. And so we were able to have some of these folks that they'd be on the ventilator for a while, you know, they'd sort of mount their immune response, get control of the virus, and then it may take a while, but it seemed that they would be able to come back off the ventilator. This still happens with Delta, but in my experience, not as frequently. And so the people who get really sick with Delta, and again, this is my personal experience taking care of these folks, is that we do everything that we can to keep them from going on the ventilator. 5 years ago, 3 years ago, you know, we'd let oxygen levels get down to a certain level. People would look like they were struggling to breathe, and we'd say, intubate them now. We hold off as long as possible. People would probably say that we were close to committing malpractice if we would wait as long as we do now before we intubate people, if we were doing this 3 years pre-pandemic, because they're just like, this person's struggling, help them. But we know, and it just seems that every person that we put on, once they hit that ventilator, it seems that things just get better for about a day, and then sort of they fall off the edge of the cliff. And so we do everything in our power to prevent that from happening. And so we do all sorts of different types of extra ways to help them breathe to try to prevent that. And that's why we don't have the success that we were having earlier. You know, very early on in the pandemic, we were figuring things out. Then we sort of hit the period where we said, okay, now we can sort of learn to manage that. So that's kind of what I'm comparing this to. And then Delta hit, and we're seeing younger people, healthier people, and then people that once they go on the ventilator, they tend not to come off. And that's really hard to watch as someone who takes care of these folks, because that's a decision that oftentimes will fall to someone like me. And so I have to say, the one is like, can we last the night to say, keep them off the ventilator? Or do I have to make the decision now to put them on the ventilator, knowing that that's probably, you know, sort of the herald of the end of their life? That's really hard. So that's why that question in particularly is very hard for me. But sort of that's where we are now. Mutations are scary. So when the virus mutates, it can pick up something that's beneficial to the virus that makes it easier to spread, you know, makes it evade our immune system. It can pick up mutations like this. It can also pick up mutations that make it worse. and so not as easy to spread. It doesn't replicate as fast, that sort of thing. It's all sort of subject to chance. And so because it's subject to chance, the more times, the more chances that we give the virus to sort of get better, get more deadly, that sort of thing, the more likely it is to happen. So if someone's infected and there's millions of viral particles in their body, every time one of those viruses replicates, it doesn't copy itself perfectly. And so every time that it sort of makes a proofreading error, that's a mutation. And so that could be beneficial to the virus, or that could be worse for the virus, which would be beneficial for people. But if it doesn't spread very well, that sort of variant will just typically die out. And so when we see these variants of interest pop up, it's because there is a mutation that was advantageous to the virus. And so every infection, every replication of the virus, that's a chance for it to pick up one of these mutations that'll make it worse for humanity. And so that's another reason to sort of try to lower the amount of community spread, the amount of virus that's in our community. So if we can reduce that by 50%, that's 50% less chances for us to develop a new, scarier mutant. For the most part, we all have access to the same medical journals. We all have access to sort of the same, websites that we use to, continue our training. And so, to be perfectly honest, I wish that those folks were up to date reading the same things that I was. And so, this is me guessing because there's no sort of data to say, hey, why are you not prescribing this? Or, why are you not recommending this? Why are you not yourself doing it? So the first thing that would be my guess is that they're just not staying up to date on the literature. And so the entirety of sort of medical knowledge, from, caveman times to the Renaissance, we probably doubled our medical knowledge a couple times. And then from the Renaissance to the Industrial Revolution, doubled 100 times. But now we're getting to the point where there's hundreds of thousands of COVID articles. I can't read all of them. I read the ones that I think that are important. And sort of there are people who we make lists of, say, here's the top 50 papers, that'll help keep you updated. But there is so much going on at this point that it's impossible to sort of know everything. The frustrating part of that probably many people have run into this interacting with the healthcare field, is we keep getting more and more subspecialized. And so now you have a doctor for your diabetes, and now you have a doctor for your blood pressure, and now you have a doctor for this. And so you don't have that sort of one doctor that you just see all the time. It's because there's so much knowledge to stay up to date. You have to get narrower and narrower and narrower in the medical field. So that's, I guess, thought one. And then the other, kind of thought that I have is that we're people too, right? So I come with my own set of flaws and foibles. And so sometimes I make, good decisions. Sometimes I make bad decisions. And, I try to learn from those. And, it's my opinion that there's almost no sort of rationale for that. And so I would chalk that up to those folks making bad decisions. And so, like I said, they're people, they're capable of making bad decisions, and it's my opinion that those are bad decisions that they're making. So there's sort of an idea that it makes infectious disease doctors sweat a little bit. And so if you can think of like a graph on sort of the x-axis or the bottom axis, you think about that's how easy it is for a virus to spread. And then sort of on the y-axis or the vertical axis, that's how deadly it is. And so, you have things like the flu virus who, is maybe a third of the way up the vertical axis, really kind of far over on the how easy it is to transmit. COVID is several steps past influenza as far as how easy it is to infect people, especially sort of the new variants. It got better at sort of infecting people. So one, COVID is much more infectious. because it's much more infectious, we had a lot more community spread. So if, for instance, 20% of your population is, infected, 1 in 5 people that you run across on the street probably have the virus and are potentially putting you at risk. So for COVID, we started off with a ton of community spread, so you just had more opportunities to meet someone who had the COVID virus. Influenza, when it sort of hit at that time, it sort of wasn't really rampant in our communities yet, and so it never really got a chance to get a foothold to raise the level of community spread to sort of make it more common in the population. The next thing, masks. Masks work. They work really well. And so everyone walking around last winter with masks on does a really good job of preventing the flu. So I don't wear N95s or anything like that when I go see a patient in the hospital with influenza. I wear a mask, just like this, because it prevents the spread. What's our threshold? What do we need to get to get back to normal? I think that this has fundamentally changed society in a lot of ways. So I don't know necessarily that things will ever be exactly what they once were, but that doesn't mean we can't get back to a place that's like way more comfortable than like hanging out in masks 24/7, and not eating out at restaurants as much as we'd like, and going to concerts and movies and that sort of thing. We need to have the level of exposure in our community really low. So you have to feel safe going to the grocery store, and if someone sneezes on you, not being terrified to go home to your kids, that sort of thing. Okay, so that's what we're talking about when, hopefully things are getting back to normal. Sort of the original sort of COVID, we sort of had an idea about you put this many people in a room and here's what super spreader events look like, and this is sort of the level that we need to get to sort of, minimize that risk. With Delta, with increased sort of the ability, the transmissibility, the ability of the virus to spread, it's a moving target. So, the targets that we said for the original virus is probably not applicable now to Delta, and it may not be, applicable to the next, variant. And to be perfectly honest, the thing that keeps me up a lot at night is that next variant. And so the way that we beat that is by getting the amount of COVID in our community, in our state, in our country, around the world, to be as low as possible to give it fewer opportunities to make that jump. But the way that you protect your families, your communities, your churches, your businesses, that sort of thing, is decrease community spread. You watch out for each other. It truly is about the community. There are ways that we know to go ahead and minimize the risk in the community. Vaccines, masks. I know that there's a lot of folks who want to express their individuality, their freedom, their, that sort of thing, by not getting a vaccine. And those are personal choices. But my recommendation really is find someone that you trust and have a conversation. My wish is that people interacted with the medical system in a way that there is a doctor or a PA or a nurse practitioner or someone that you know and trust and have built a relationship and can ask the questions, have the conversations. Hopefully, if that person is me, great. And if this did it for you, great. But again, this is not about one of us or two of us. This is about our community. And so, to get to the point where life goes back to normal, we need buy-in from the majority of our community.